Hi everyone, this is Doc Ina and welcome to my lecture on cardiovascular disorders in pregnancy. To download my lecture deck, please go to my WordPress site, Doc Ina Obigaine. Reference for this lecture is Williams Obstetrics 25th edition, Chapter 49, Cardiovascular Disorders. This is the outline of my lecture. Please note that this chapter in Williams Obstetrics is quite long, so I just chose which topics to discuss for this, particularly for this lecture. So now let's start with the physiological considerations in pregnancy. The marked pregnancy-induced anatomical and functional changes in cardiac physiology can have a profound effect on the underlying heart disease of the woman. Cardiac output increases approximately 40% during pregnancy, and usually this takes place by 8 weeks age of gestation and is maximal during mid-pregnancy. This early rise stems from augmented stroke volume, which results from lowered vascular resistance in a pregnant woman. The greater end diastolic ventricular volume that results from pregnancy, hypervolemia, gives rise to higher resting pulse and stroke volume. The normal left ventricular function is maintained during pregnancy, and so pregnancy is really not characterized by hyperdynamic function or a state of high cardiac output. These are some of the hemodynamic changes in normal pregnant women at term. Women with underlying cardiac diseases may not always accommodate these changes, and ventricular dysfunction leads to cardiogenic heart failure. A few women with severe cardiac dysfunction can experience evidence of heart failure before mid pregnancy. In others, heart failure may develop after 28 weeks age of gestation when pregnancy induced hypervolemia and cardiac output reach their maximum. In most, however, heart failure develops peripartum during labor, during delivery, and several common obstetrical conditions add undue cardiac burdens. Some of these include preeclampsia, hemorrhage, and anemia, and also sepsis. So in a pregnant woman, so in a pregnant woman, ventricular volumes and mass increase to accommodate pregnancy-induced hypervolemia. And this is usually reflected by greater end systolic and end diastolic dimensions. All of these adaptations return to pre-pregnancy values within a few months postpartum. So how do we diagnose heart disease in a pregnant woman? Of course, we start first with symptoms and signs that the patient manifest. For symptoms, usually our patients with heart disease will manifest with progressive dyspnea, orthopnea, nocturnal cough, hemoptysis, syncope, and chest pain. For the signs, usually our patients will present with cyanosis, clubbing of fingers, persistent neck vein distension, systolic murmur about grade 3 over 6 or even greater, diastolic murmur, cardiomegaly, persistent tachycardia and or arrhythmia, persistent split-second sound, fourth heart sound, and there's also signs of pulmonary hypertension. The physiological adaptations of normal pregnancy can induce symptoms and alter clinical findings that may confound the diagnosis of heart disease. For example, in a normal pregnant woman, functional systolic heart murmurs are common. Respiratory effort is accentuated, and edema frequently accrues in lower extremities after mid-pregnancy, and fatigue and exercise intolerance often develop. So these are the normal cardiac examination findings in a pregnant woman. Note that there is external jugular vein distension. You can also auscultate for a venous hum, a mammary souffle. The S2P is increased and there's an S2 split. S1M is increased and widely split. There's occasional S3 and aortic or pulmonary flow murmurs. So, to confirm our suspicion that our pregnant patient may have signs and symptoms of a possible cardiac disorder, then we have to confirm it with using diagnostic studies such as 12-lead ECG, 2D echo, and chest X-ray. And these studies will provide the data necessary for evaluation in most of our patients. In the electrocardiogram or ECG, an average 15-degree left axis deviation is found as the diaphragm is elevated in advancing pregnancy. So this 15-degree left axis deviation is normal in a pregnant woman. Other findings that are seen in a normal pregnant woman that do not necessarily point to a disease are the following. There's a reduced PR interval, inverted or flattened T waves, and a Q wave in lead D3. Pregnancy does not alter voltage findings. Atrial and ventricular premature contractions are relatively frequent. If you're going to request for a chest x-ray for your pregnant patient, please make sure to note that she is pregnant in your request form and she has to use a lead apron or an abdominal shield to minimize fetal radiation exposure. Heart silhouette is normally larger during pregnancy, and this is accentuated further with a portable AP chest radiograph. For 2D echo, this permits accurate diagnosis of most heart diseases during pregnancy, and some normal pregnancy-induced changes include a small increase in the dimensions of all cardiac chambers, a slight but significant growth in left ventricular mass, and a greater tricuspid and mitral valve regurgitation. So this is how we classify a functional heart disease in a pregnant woman. The New York Heart Association clinical classification is based on past and present disability and is uninfluenced by physical signs. So basically we have four classifications. So class 1 is uncompromised, where the patient manifests no limitation of physical activity and she has no symptoms of cardiac insufficiency or experience anginal pain. For class 2, the patient has slight limitation of physical activity. She is comfortable at rest. For class 2, the patient has slight limitation of physical activity. She is comfortable at rest, but if ordinary physical activity is undertaken, discomfort in the form of excessive fatigue, palpitation, dyspnea, or anginal pain may result. For class 3, there is marked limitation of physical activity. The patient is usually comfortable at rest, but less than ordinary activity may cause excessive fatigue, palpitation, dyspnea, or anginal pain. And lastly, the most severe would be class 4, where the patient is severely compromised and there's inability to perform any physical activity without discomfort. Symptoms of cardiac insufficiency or angina may develop even at rest. An even more comprehensive risk stratification system is the Modified World Health Organization or WHO risk classification of cardiovascular disease and pregnancy, which is shown in this table. It is especially useful for assessing maternal risk and for preconceptional counseling. Some studies have shown also that this modified WHO classification provides the greatest predictive accuracy for cardiac complications during pregnancy. So we have here the risk category WHO1, where the risk of the patient is no higher than the general population, and the associated conditions would be the following: uncomplicated small or mild pulmonary stenosis, VSD, patent ductus arteriosus, mitral valve prolapse with no more than trivial mitral regurgitation, successfully repaired simple lesions such as ostium secundum atrial septal defect, VSD, patent ductus arteriosus, and total anomalous pulmonary venous drainage. So for WHO2 risk category, the patient has small increase in risk of maternal mortality and morbidity. And the associated conditions would be, if otherwise uncomplicated, unoperated ASD, repaired fallow tetralogy, and most arrhythmias. Now let's discuss labor and delivery. In general, vaginal delivery is preferred and labor induction is usually safe. Planned cesarean delivery conferred no advantage for maternal or neonatal outcomes, and cesarean delivery is usually limited to obstetrical indications. Based on a review or based on a study, Simpson recommended cesarean delivery for women with the following conditions. First is a dilated aortic root greater than 4 centimeters or aortic aneurysm, an acute severe congestive heart failure, a recent myocardial infarction, severe symptomatic aortic stenosis, warfarin administration within 2 weeks of delivery, and the need for emergency valve replacement immediately after delivery. During labor, the mother with significant heart disease should be kept in a semi-recumbent position with a lateral tilt. Vital signs are taken frequently between contractions. Increases in pulse rate above 100 beats per minute, or respiratory rate that's above 24 cycles per minute, particularly when the patient is experiencing dyspnea, may suggest impending heart failure. For evidence of cardiac decompensation, intensive medical management must be instituted immediately. Delivery itself does not necessarily improve the maternal condition and, in fact, may worsen it. So, for these cases, unless of course we're talking about fetal distress, we don't really need to deliver immediately. So, moreover, emergency cesarean delivery may be particularly hazardous. Clearly, both maternal and fetal status must be considered in the decision to hasten delivery under these circumstances. How about the choice of analgesia and anesthesia? Relief from pain and from apprehension is very, very important, and continuous epidural anesthesia is recommended for these patients. The major problem, though, for conduction analgesia is maternal hypotension, and this is dangerous in pregnant women with intracardiac shunts in whom flow may be reversed. Hypotension can also be life threatening if there is pulmonary arterial hypertension or aortic stenosis because ventricular output is dependent on adequate preload. In women with these conditions, narcotic regional analgesia or general anesthesia may be preferable. Subarachnoid blockade is not generally recommended, or this is what we call the spinal anesthesia, is not really recommended in women with significant heart disease due to the associated hypotension. For cesarean delivery, epidural anesthesia is preferred by most clinicians, with caveats for its use with pulmonary arterial hypertension. How about during the puerperium? Women who have shown little or no evidence of cardiac compromise during pregnancy, labor, or delivery may still decompensate postpartum or during the puerperium. Fluid mobilized into the intravascular compartment and reduced peripheral vascular resistance placed higher demands on myocardial performance. Postpartum hemorrhage, anemia, infection, and thromboembolism are much more serious complications with heart disease, especially during the puerperium. For puerperal tubal sterilization after vaginal delivery, the procedure can be delayed up to several days to ensure that the mother has normalized hemodynamically and that she is afebrile, not anemic, and ambulating normally. How about considerations for anticoagulation? Now, this is critical for pregnant women with mechanical prosthetic valves. Warfarin is the most effective anticoagulant for preventing maternal thromboembolism, but this causes harmful fetal effects, especially harmful teratogenic fetal effects. Anticoagulation with heparin is less hazardous for the fetus. However, the risk of maternal thromboembolic complications is much higher. Warfarin, as I've said, is teratogenic and may cause miscarriage, stillbirths, and fetal malformations. The American College of Cardiology and the American Heart Association estimates that the risk of embryopathy is dose dependent, with the lower risk less than 3% if the dose of warfarin is less than 5. If the dosage is more than 5 milligrams per day, then the risk of embryopathy exceeds 8%. Anticoagulation for mechanical valves using low-dose unfractionated heparin is definitely inadequate and carries a high associated maternal mortality rate. If full anticoagulation with high dose or with dose associated UFH or low molecular weight heparin is used, meticulous monitoring is recommended. The activated partial thromboplastin time or APTT should be at least 2 times the control, or anti-XA level should be 0.8 to 1.2 units per ml at 4 to 6 hours post-dose. So, any of these four regimens may be used. So we can use an adjusted dose, low molecular weight heparin, given twice daily with a peak anti-XA level drawn 4 hours after dosing. We can also use adjusted unfractionated heparin, dose every 12 hours to keep the mid-interval APTT twice control, or anti-XA level between 0.35 to 0.70 units per ml, low molecular weight heparin or unfractionated heparin given as previously described until 13 weeks, and then warfarin is substituted until near delivery, at which time it is replaced by low molecular weight heparin or unfractionated heparin. In women judged to carry a high risk of thrombosis and for whom the efficacy and safety of heparins are concerned, warfarin is suggested throughout pregnancy. Heparin is then substituted close to delivery. In addition, aspirin 75 to 100 milligrams is given daily. Heparin is discontinued just before delivery. Now, if delivery supervenes or happens while heparin is still being given, an extensive bleeding will be encountered. Then, protamine sulfate is given intravenously. Anticoagulant therapy with warfarin or heparin may be restarted 6 hours following vaginal delivery, usually with no problems. Following cesarean delivery, on the other hand, full anticoagulation is withheld, but the optimal duration is not exactly known. Now, the ACOG advises resuming unfractionated or low molecular weight heparin 6 to 12 hours after delivery. Let's talk about some of the valvular heart diseases and its implications during pregnancy. And these are some of the cardiac valve disorders and the possible consequences during pregnancy. So first, let's talk about mitral stenosis. Usually, this is due to rheumatic endocarditis, and the contracted valve impedes blood flow from the left atrium to the ventricle. The normal mitral valve surface area is usually 4 centimeters squared, and when stenosis narrows this to less than 2.5 centimeters squared, then symptoms usually develop. With more severe stenosis, the left atrium dilates and the left atrial pressure is chronically elevated and significant passive pulmonary hypertension usually develops. There's increased preload of normal pregnancy, and other factors that raise cardiac output may cause ventricular failure and pulmonary edema. The resulting pulmonary venous hypertension and pulmonary edema create symptoms of dyspnea, fatigue, palpitations, cough, and hemoptysis. How do we manage mitral stenosis in a pregnant woman? Of course, we recommend limited physical activity, and if symptoms of pulmonary congestion develop, activity is further reduced, dietary sodium is restricted, and diuretics are given. A beta blocker drug therapy slows the ventricular response to activity. For new onset atrial fibrillation, we can give intravenous verapamil or electrocardioversion. For chronic fibrillation, we can give digoxin, a beta blocker, or a calcium channel blocker, which can slow ventricular response. For therapeutic anticoagulation is indicated with persistent fibrillation, left atrial thrombus, and a history of embolism. Surgical intervention is considered for women with symptomatic severe mitral stenosis and in those with lesser degrees of mitral stenosis where the mitral valve area is 1.5 to 2 centimeters squared, complicated by recurrent systematic or systemic embolization or severe pulmonary hypertension. For patients with mitral stenosis, we prefer epidural anesthesia, but we have to avoid fluid overload for these patients. So most prefer vaginal delivery instead of a cesarean. And with severe stenosis and chronic heart failure, insertion of a pulmonary artery catheter may help guide management. Next is mitral insufficiency. So acute mitral insufficiency or regurgitation is usually caused by chordae tendineae rupture, papillary muscle infarction, or leaflet perforation from infective endocarditis. Chronic mitral regurgitation, in contrast, may derive from rheumatic fever, connective tissue diseases, mitral valve prolapse, or left ventricular dilatation of any etiology, for example, a dilated cardiomyopathy. Less common causes include a calcified mitral annulus, possibly some appetite suppressants, and in older women, ischemic heart disease. Mitral valve vegetation, such as Liebman-Sachs endocarditis, are relatively common in women with APAS. During pregnancy, mitral regurgitation is similarly well tolerated, probably because the lowered systemic and vascular resistance yields less regurgitation, and heart failure rarely develops during pregnancy in patients with mitral regurgitation. How about mitral valve prolapse? This usually involves a pathological connective tissue disorder, often termed myxomatous degeneration, which may involve the valve leaflets themselves, the annulus, or the chordae tendineae. This usually is asymptomatic and are diagnosed only during routine examination or when echocardiography is done. The few women with symptoms have anxiety, palpitations, atypical chest pain, dyspnea with exertion, and syncope. Pregnant women with mitral valve prolapse rarely have cardiac complications, and hypervolemia may even improve alignment of the mitral valve, and women without pathological myxomatous degeneration generally have excellent pregnancy outcomes. For aortic stenosis, this is usually a disease of the aging, but if we see aortic stenosis among younger women, this is most likely a congenital lesion. A normal aortic valve has an area of 3 to 4 centimeters squared with a pressure gradient that's less than 5 millimeter Hg. Now, if the valve area is less than 1 centimeter squared, there is severe obstruction to flow and a progressive pressure overload on the left ventricle, and thus concentric left ventricular hypertrophy may develop. Characteristic manifestations develop late and include chest pain, syncope, heart failure, and sudden death. Mild to moderate degrees of stenosis are well tolerated, however, severe disease is very much life-threatening. The principal underlying hemodynamic problem among patients with aortic stenosis is the fixed cardiac output associated with severe stenosis. Now, during pregnancy, several common events acutely lower the preload further and thus aggravate the fixed cardiac output. Complication rates are higher if the aortic valve area measures less than 1.5 centimeters squared. Women with valve pressure gradients greater than 100 millimeter Hg appear to be at greater risk. So how do we manage patients or pregnant patients with aortic stenosis? For asymptomatic women, actually there's no treatment except close observation. However, for a patient with aortic stenosis who is symptomatic, then we recommend strict limitation of activity and prompt treatment of infections. If symptoms persist despite bed rest, then we may recommend surgical intervention. Abrupt drops in end-diastolic volume may result in hypotension, syncope, myocardial infarction, and sudden death. Thus, we have to avoid diminished ventricular preload and maintain the cardiac output. During labor and delivery, affected women are best managed on the wet side. This provides a margin of safety in intravascular volume in anticipation of possible hemorrhage. In women with a competent mitral valve, pulmonary edema is very rare. During labor, narcotic epidural anesthesia seems ideal and avoids potentially hazardous hypotension. In hemodynamically stable women, forceps or vacuum delivery is used for standard obstetrical indications. How about aortic insufficiency or regurgitation? Aortic valve regurgitation or insufficiency allows diastolic flow of blood from the aorta back into the left ventricle. Frequent causes of abnormal insufficiency or aortic insufficiency are rheumatic fever, connective tissue abnormalities, congenital lesions, bacterial endocarditis, or aortic dissection. Aortic and mitral valve insufficiency have both been linked to the appetite suppressants fenfluramine and dexfenfluramine and to the ergot-derived dopamine agonists cabergoline and pergolide. With chronic insufficiency, left ventricular hypertrophy and dilatation develop and are followed by slow onset fatigue, dyspnea, and pulmonary edema, although rapid deterioration usually follows. Aortic insufficiency is generally well tolerated during pregnancy, and like mitral valve insufficiency, diminished vascular resistance is thought to improve hemodynamic function. If symptoms of heart failure develops on the other hand, then diuretics are given and bed rest is encouraged. Lastly, we have pulmonic stenosis. So this is usually congenital and may be associated with a tetralogy of Fallot or the Noonan syndrome. Hemodynamic burden of pregnancy can precipitate right-sided heart failure or atrial arrhythmias in women with severe stenosis. Now, surgical correction ideally is done before pregnancy, but if symptoms progress, then a balloon valvuloplasty may be necessary antepartum. Let's go now to discussing congenital heart diseases. So let's start with atrial septal defects. Most atrial septal defects or ASD are asymptomatic under the third or fourth decade. and pregnancy is well tolerated unless pulmonary hypertension has developed. Treatment of ASD during pregnancy is indicated for women with congestive heart failure or arrhythmia. With the potential to shunt blood from right to left, a paradoxical embolism, that is, entry of a venous thrombus through the septal defect and into the systemic arterial circulation, is possible and may cause an embolic stroke. Compression stockings and prophylactic heparin have also been recommended for pregnant women with ASD who is immobile or has another risk factor for thromboembolism. How about VSDs? These lesions usually close spontaneously during childhood. Now, if the defect measures less than 1.25 centimeters squared, then pulmonary hypertension and heart failure do not develop. However, if the effective defect size exceeds that of the aortic valve orifice, then symptoms rapidly develop. Adults with unrepaired large defects develop left ventricular failure and pulmonary hypertension and have a high incidence of bacterial endocarditis. Pregnancy is generally well tolerated for patients with small to moderate size shunts. If pulmonary arterial pressures reach systemic levels, however, there is reversal or bidirectional flow, and this is what we call the Eisenmenger syndrome, which we will discuss in the next slide. When this develops, the Eisenmenger syndrome, the maternal and fetal mortality rates are significantly higher, and thus pregnancy is not generally advisable. So what is Eisenmenger syndrome, or what other cardiologists would say Eisenmengerization? This describes the secondary pulmonary hypertension that arises from a cardiac lesion. The syndrome develops when the pulmonary vascular resistance exceeds systemic resistance and leads to the concomitant right to left shunting. The most common underlying defects are atrial or ventricular septal defects and persistent ductus arteriosus. So if there's a right to left shunting, of course, the blood does not go through the lungs and will not be oxygenated anymore. So usually patients are asymptomatic for years, but eventually pulmonary hypertension becomes severe enough to cause this shunting. So let's discuss pulmonary hypertension. The normal resting mean pulmonary artery pressure is about 12 to 16 mm Hg. Now, pulmonary hypertension develops when the resting mean pulmonary pressure is more than 25 mm Hg. And this is the comprehensive clinical classification of pulmonary hypertension. So basically, we have 5 clinical classification. These are pulmonary arterial hypertension, pulmonary hypertension due to left heart disease, pulmonary hypertension due to lung disease and or hypoxia, chronic thromboembolic pulmonary hypertension, and pulmonary hypertension with unclear and or multifactorial mechanisms. How do we diagnose this condition? Usually symptoms may be vague, and dyspnea with exertion is the most frequent symptom. With group 2 disorders, orthopnea and nocturnal dyspnea are also usually present. Angina and syncope occur when right ventricular output is fixed, and they suggest an advanced disease. Chest X-ray often shows enlarged pulmonary hilar arteries and attenuated peripheral markings. It also may disclose parenchymal causes of hypertension. Non-invasive 2D echo can provide an estimate of pulmonary artery pressures, although cardiac catheterization remains the standard of measurement. What's the prognosis of pulmonary hypertension? Pregnancy should be contraindicated with severe disease, especially in women with pulmonary arterial changes, mostly cases in group 1. With milder disease from other causes, group 2 being the most common, the prognosis is better for pulmonary hypertension, and all tolerated pregnancy reasonably well. Regardless of the etiology, the final common pathway of pulmonary hypertension is right heart failure and death, and the average survival length after diagnosis of pulmonary hypertension is about 4 years or less. How do we manage patients with pulmonary hypertension? The treatment of symptomatic pregnant women usually includes activity limitation and avoidance of the supine position later in gestation. Diuretics, supplemental oxygen, and pulmonary vasodilator drugs are standard therapy for symptoms. Some experts also would recommend anticoagulation. Given So these are some of the examples of intravenous pulmonary artery vasodilators. We have the prostacyclin analogs, the inhaled nitric oxide, phosphodiesterase 5 inhibitors in the form of sildenafil, and bosentan, which is an endothelin receptor antagonist, which is, of course, teratogenic and should be contraindicated during pregnancy. During labor and delivery, patients with pulmonary hypertension are at greatest risk when venous return and right ventricular filling are diminished. Now, to avoid hypotension, assiduous attention is given to epidural anesthesia induction and to blood loss prevention and treatment at delivery. Now, lastly, we will talk about infective endocarditis. The greatest risk for endocarditis are those with congenital heart lesions, intravenous drug use, degenerative valve disease, and intracardiac devices. Among intravenous drug abusers and those with catheter-related infections, usually the bacteria that is involved is Staphylococcus aureus. For patients with prosthetic valve infections, the bacteria involved is usually Staphylococcus epidermidis. How do we diagnose patients we suspect to have bacterial endocarditis? Usually, these patients present with fever and chills, anorexia, fatigue, and other constitutional symptoms, and the clinical clues would include the following: murmurs, anemia, proteinuria, and manifestations of embolic lesions that include petechiae, focal neurologic changes, chest or abdominal pain, and ischemia in an extremity. In some cases, heart failure may develop. And the formal diagnosis is made using the Duke criteria as seen in this table, which includes positive blood cultures for typical organisms and evidence of endocardial involvement. So let's talk about endocarditis prophylaxis. So the American Heart Association recommends prophylaxis for dental procedures in those with number one, a prosthetic valve or prosthetic material used in valve repair, prior endocarditis, unrepaired cyanotic heart defect or repaired lesions with residual defect at prosthetic sites, and valvulopathy after a heart transplantation. The ACOG, on the other hand, does not recommend endocarditis prophylaxis for either vaginal or cesarean delivery in the absence of pelvic infection, except with the lesion cited above. Women at highest risk for endocarditis are those with cyanotic heart disease, prosthetic valves, or both. And prophylactic regimens are administered as close to 30 to 60 minutes before the anticipated delivery time as is feasible. The ACOG recommends the following regimen. So the standard intravenous regimen would be ampicillin 2 grams or cefazolin or ceftriaxone 1 gram. For patients who are penicillin allergic, we can give cefazolin or ceftriaxone or clindamycin. Or if oral, we can also give amoxicillin 2 grams. American Heart Association and the European Society of Cardiology recommends the following regimen. For the standard regimen, we have amoxicillin 2 grams per RM or ampicillin 2 grams IV or IM. For patients who are penicillin allergic, we can give clarithromycin or azithromycin, cephalexin, clindamycin, cefazolin, or ceftriaxone. So in summary, we have discussed the cardiovascular disorders and the physiological considerations during pregnancy, the diagnosis of cardiovascular disorders during pregnancy, the peripartum management considerations, and we also discussed the etiology and management of valvular heart disease, congenital heart diseases, pulmonary hypertension, and infective endocarditis during pregnancy. That's it for my lecture. Thank you for watching this lecture and please don't forget to subscribe in my YouTube channel and my WordPress site. Thank you.